So we're going to be talking about MTHFR in ophthalmology. It stands for methylenetetrahydrofolate reductase. And as you know, folate is a vitamin, and a vitamin means it is a vital amine, and that means you need it. And so this vital amine, the vitamin, in this case is folate, and folate is involved in a number of metabolic processes, but the one that applies to us in ophthalmology is the conversion of methionine to homocysteine and back around. And that requires both B12 and B9 because the methyl donor is mediated by the enzyme methylene tetrahydrofolate reductase in the conversion of tetrahydrofolate to dihydrofolate, and that requires the vitamin folate. So if you don't have folate, you can have a vitamin deficiency in folate or in B12, and that will lead to a rise in homocysteine because you block the conversion from the homocysteine to methionine, and that homocysteine, very controversially, is linked to increased graded risk for thrombosis. So that means NaION and ischemic thirds and sixths. The other way that you need to know about this MTHFR is there's genetic versions. So it's not a deficiency of the vitamin, folate, or B12, but genetic versions. And these polymorphisms occur at positions 677 and 1289. And if you are homozygous, that's two bad copies of 677, you might drop your MTHFR enzymatic activity to 25%, and that's going to lead to elevated homocysteine. If, however, you're homozygous at 1289, the other mutation, you're probably only looking at a 67% function, which is probably not enough to cause any problems. But the second worst after homozygous for 677 is when you're heterozygous, but you're at two locations, and that is called a compound heterozygous. And so when you're a compound heterozygote, you have one bad copy of 677 and one bad copy of 1289, and that probably leads you to like a 40 to 50% function of MTHFR, and that's going to cause a rise in the homocysteine. And so we used to give all these people folate, but because the controversy continues, maybe we're just treating ourselves. But you do need to know about this. The genetics societies don't actually recommend testing for these genes anymore. In the past, they used to. And so we're just measuring homocysteine and probably giving them folate, but sometimes you're just treating the doctor and not really treating a disease because it's controversial whether the folate is actually making a difference in the major adverse cardiovascular event outcomes, and for us, ischemic ophthalmopathy and ischemic palsies.